Kathy is our great leader on HIV/AIDS, and I think has some very good comments for us on collaboration to solve problems. Kathy.
Thank you. It really is an honor to be a part of this panel and to see that the disease groups have a voice at the table, because it really does come down to collaboration. You know, we know that today is World AIDS Day, and I really want to stress that for us at Hyacinth, and I think for many of our colleagues in the AIDS world, it's a difficult day, because the message that often gets out is that AIDS is now a chronic manageable disease. And for many of the clients that we serve, it's not. You know, they're folks who are diagnosed late stage in the disease. They are the urban poor. They face addiction. They're facing homelessness. They're facing all these other struggles that most of us in this room can't even begin to imagine. And then when you start talking to them about treatment adherence, it's not always the first thing that is on their plate at that time. So, you know, there's this recognition and this work that we do to drive home the fact that HIV is a social justice issue in this country. And for as far as the advances have come, we're not out of the woods by any stretch of the imagination. When you look at medical innovation, you know, HIV really, I think, has been certainly a disease that has benefited greatly, tremendously from innovation. You can look at it through vaccine development. You know, we don't have a vaccine yet. There was a recent study in Thailand where they saw that by combining 2 previous vaccines, they were able to reduce the rate of infection by 31%. The New England Journal of Medicine later came back and said, well, no, it wasn't 31%, it was 26%. But what was exciting to us as advocates is that they got to the point to recognize that one vaccine alone is not going to work, that much the same way we treat the disease with dual therapies, we have to look at a vaccine in that way. So again, through innovation, that became possible. When you look at treatment, I mean, across the board, treatment has been the history of innovation. You know, you've gone from one drug, AZT, which came out in the late 90s or the mid 90s and really changed the face of the epidemic in the world, to now where we've gotten it to hopefully a client can take one pill, and in that pill are the multiple medications that a person needs. So through the ease of therapies, we've been able to help people live with the disease a little bit easier. We also now are starting to look at whether or not these treatments can be effectively used as prevention, which is really, I think, quite remarkable. If you look at, if you can get somebody onto HIV treatment and you can reduce the level of viral load that is in that person's body, the idea now is that maybe then they're less infectious to other people. So the goal in HIV is always about access to care. It's about finding people. It's about getting them tested, getting them into care, and then providing the support so that they can be successful in their adherence. The other piece with prevention, look at women. I mean, women really don't have a tool in their hands that they can use to protect themselves from HIV. Microbicide development has been, you know, in the works for years, and we still don't have it. And, you know, in New Jersey, 35% of the people who are currently living with HIV are women. 64% of them are between the ages of 20 and 49 years old. I mean, clearly we need to be able to develop a tool that can let women take some control over their bodies. And the fourth piece for us is diagnostics. If you look at the ease with which we are able now to test people for HIV, you know, back in the day, it was a blood test followed up with a second blood test. And again, the majority of the folks in the state who are infected are sort of transitory. You know, they are the urban poor. They're, you know, trying to find them to get them tested the first time is difficult enough. But then to have them come back 2 weeks later for a follow-up was virtually impossible. Well, now we can do it with a cotton swab and a swipe of their cheek. And we're now starting to do the confirmatory with the second swab, so that we don't lose that client. We can get them in, we can engage them either in a mobile site or through our office, and we can keep them there and get them, you know, the goal is to get them tested, and again, get access to care and treatment. So the piece of all this that is important to Hyacinth and to many of our colleagues is how the community partnered with the NIH, we partnered with the FDA, we partnered with the CDC way back in the 80s and the early 90s to make sure that the work that was being done, that the research that was being done, that the drugs that were being developed were in concert with the community, that it was the community who was really pushing these. And, you know, as advocates like Marty Delaney from Project Inform in San Francisco, who really could pick up the phone and call Tony Fauci at NIAID at the NIH and say, hey, what are you doing? And you're not doing enough and you need to do more. And I think that through that work, you know, it was the AIDS community that was able to develop the parallel track so that when a drug is in clinical trials, we can get those drugs to the people who need it most. It was the AIDS community that developed the use of compassionate care. And today, again, I think the role that the AIDS community plays, it's a dance that we do with the pharmaceutical industry, and I think it's a dance that we do pretty well. You know, we hold them accountable, we work with them, we look at the drug pricing, we look at the distribution, and, you know, in the AIDS world, we have what we call the smell test. And if it doesn't smell right, we're going to call you up and say, hey, you know, we need you to look at this. We need the drugs to be distributed nationally, we need the drugs to be distributed globally, and nobody should be paying for it on somebody else's back. And so those conversations are a normal part of the work that we do. The other piece that comes into play for us is advocacy. You know, our public policy advocates can go to the NIH and they can go to the CDC and they will look to get the funding that is necessary for research. And we can go, once the drugs are in process and are out there, the advocacy then becomes about utilization, and we can go to the state legislature or we can go to the feds and talk about how do we make these drugs accessible, how do we keep open drug formularies, how do we make it so that the people who most need these drugs have access to the drugs. And so, having said all of that, I really do want to drive home the point about collaboration, because I don't think that any of us really should be operating in silos, because it doesn't really benefit the other piece. And I think that there are ways that we can work together and get far more done than if we each sort of, you know, have the blinders on and focus on our own particular world. Thank you.
Thank you so much. David?